Good evening everyone. Welcome to Unacademy, where you can crack on NEET PG exams with us with our top educators, quality content and have a great learning experience. So guys, let's crack NEET PG together. I'm Dr. Sasha Menon Remedies. I've done my MBBS from Father Muller Medical College, Mangalore, MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. Today's topic will be capnography. I will be taking it in 2 parts, as basically carbon dioxide monitoring during general anesthesia. I'll be taking it in 2 parts. I'll deal with part 1 today, and tomorrow I will be taking part 2. This was supposed to be taken yesterday, but because of some technical problems, I was unable to take it. But I will be covering it today and tomorrow in 2 parts. I'll be taking now a little on NEET PG. It's one of India's largest learning online platform where you get plus subscription and access to unlimited live and recorded courses from India's best educators. Now, what do you get out of Unacademy? Basically, we have our daily life classes. So when you go to a coaching institute, there's a lot of waste of time and energy, as you have to get up, you have to take the effort to go till the coaching institute. Of course, this is in the time when all coaching large gatherings were actually happening. But once we get back to that, the issue will rise again. So, and in a coaching institute, the educator has a limited amount of time, say about 1 hour or 1.5 hours to cover his or her lecture. These are long lectures. It is really difficult, and it is difficult for him or her to clear everyone's doubts because it's a live class, so there will be a lot of distractions happening for the educator too. So it's very difficult to clear everyone's doubts. These are very large classes, and while the class is going on, the flow of the educator gets interrupted. Whereas over here, you can chat with the educator during the class. You can send your queries, and your educator will reply post the class, right? So your queries will be cleared once the educator is done with the class. So if the educator feels he can clear your queries during the class too, it will be done. And we can engage in active discussions all while the class is going on. Now these are structured courses. They are all in line with your exam syllabus. So all the educators on Unacademy, they research and see how much marks are allotted for that particular subject, what is required out of that particular subject, and the course structure is prepared for you all in the best possible way. Now your live tests and quizzes, so they help you evaluate your preparation with so we regularly conduct a few classes, and then we make live tests and quizzes on these classes. So these will help you evaluate your preparation on a regular basis. You will know where you stand, you will know how you're doing in your course. So these are all will help you all benefit from it, right? So we try our best to see that you all benefit maximum. Of course, there are, and the most important part, it's unlimited access. So one subscription gets you access from all our live and recorded courses, and you can watch from the comfort of any of your devices. Wherever you are sitting, from the comfort of your home, you can just access from whichever device you have. You have to just download the app or go onto YouTube and you can access it. These are some of our top educators. Dr. Nikita Nanwani, she's a NEET PG mentor for radiology as well as mnemonics and concept focusing on must-know topics. Dr. Mohammad Azam, Dr. Divish Mishra, Dr. Preeti Sharma. So mnemonics is a very important part, right? So it's very good because there are so many subjects. It's very difficult to remember everything. So it's very good to have mnemonics, kept there kept there. So one is mnemonics. You all can concentrate on mnemonics and also make your own mnemonics. It will help you all because it's very difficult to remember everything that someone else has done. Of course, please refer you. It's because some basic ones are very easy. Sometimes what someone else would have made would be very easy and would be very easy for you all to remember. But also make it a practice to make your own mnemonics so that you all will remember better. And of course, some people mnemonics just don't help. Like for me, no mnemonics help. I just cannot remember. So you have to find a way about remembering. These are some of our courses offered. So as you can see, there are about 19 subjects that you all have to cover and various courses under each subject. Now, like I told you, the smaller subjects like anesthesia, psychiatry, radiology, these are not small subjects. I say they are small because during your MBBS, not much weightage is given to them. You'll have maybe a 1 month posting or a 15-day posting during internship, and 1 month posting in between whatever your final year. I think not you don't have to concentrate much on these subjects during your MBBS, right? You're not giving university exams in that. These are specialist subjects. So this kind of so you kind of think that these subjects are small, but these subjects, that's why they call small subjects, but these subjects are not small. They are vast in their own, and it just can go on and on in these subjects, and there is lots to cover. So NEET PG wise, so you all just study the cream of the cake, right? You all just need to know the cream of the cake during MBBS. So even here, NEET PG, the course structure is such that there are 11 marks allotted to these subjects, and again they will give you the cream of the cake questions only. They're not going to give you questions from, you know, in depth. Like your anatomy, physiology have been allotted 44 marks, so they can ask you anything from anywhere in that, right? You need to go in depth, you need to know everything because you have spent 1 year on these subjects studying, so you need to know them in depth. They can ask you anything from anywhere. But generally with anesthesia, psychiatry, radiology and all that, they will just ask you the basic things. So concentrate. We are here to help you all. We will try our best. We are trying our best to help you all achieve maximum. Now, these are some of the ongoing courses on our platform. Like you can see, course on neurophysiology, course on GI surgery, cardiovascular thoracic surgery, capsule on larynx, respiratory system, and a course on pathology. Now coming to our subscription, as you can see, there are 5 types of subscription on your screen. So now your 6 month subscription, those who are planning to give NEET PG this year, the 6 month subscription should subsidize for you all, should be enough for you all. Whereas your 12 and the 24-month subscriptions, as you can see, if you are planning to drop a year, please go ahead. I am telling you, it is good. 12 and 24-month is what I would recommend to you all. So what happens is, like I said, those smaller so-called smaller subjects, your anesthesia, radiology, etc. So those subjects, basically, how do I put it? Those subjects, like, you know, how can I put it to y'all? So yeah, so y'all don't know much about the subjects, right? Now when you're doing, y'all might have made up your mind that y'all want to study medicine or whatever, orthopedics or whatever. Take some one of the subjects where you have to spend a year in MBBS. Now, okay, fine, because you have gone through that subject, you like it, you want to spend time. Now, when you're studying, you don't realize, okay, fine, maybe you're not going practically into these subjects like psychiatry and all. But when you're studying, you actually get a liking, because at the end of the day, you have to study these subjects, right? You might actually get a liking to one of these other subjects which you have not gone into depth, and you might realize, oh, I like this subject, I think I want to do this. See, remember, you'll have to do something for the rest of your life. So take your time, decide, because you shouldn't, it's not about regretting, but you all should enjoy what you all do, right? So you all should choose the correct subject. So that's where your 12 and 24 months will really help you. Plus it is more economical. Now how is it economical? See, it's a one-time subscription. So after your subscription is up, you have to subscribe again if you want to clear your doubts, if you want to see the review the classes again, chat with your educator, you need to renew your subscription. Now that's, so you'll have to pay all over again the six months amount, right? Or the 1 month amount. Instead of that, go for the 12 months. So for the same amount, you have 1 whole year to clear. 1 whole year to clear your doubts, and of course to study, and nobody will ask you how long you have taken to clear NEET PG. At the end of the day, it is knowledge. It will only benefit you. Nobody is, but you all have to practice and work hard. That is the mantra. Practice, work hard, revise. It's not like take 12 months and take your own sweet time, waste time. No, you all have to be hardworking, practice. So at the end of the day, it's knowledge. Nobody is going to ask you all how long you all took. As you can see at the bottom of the screen, this is my code SASHA. You'll get a 10% discount. So, so this will be your 10% discount, 10% off, as you can see over here, even for your 24 months. The 10% applies to all these. You will get a 10% off if you use my code. So coming to the NEET PG subscription. So as you can see, again 24 months. Like I said before, no one is going to ask you all how long you all took to clear NEET PG. So use my code like you can see at the bottom of the screen and get available 10% discount. Now coming to my class for today, which is capnography. I'll be taking it in 1.5 hours. So it's a little long class and I will be taking the rest of the class tomorrow too. So in 2 parts I will take it. I know it's a little long class, but let's see. But let's do the best that we can, right? Just a sec, guys. Yeah. So, like I said, I'll be taking it in 1.5 hours. So let's get on with our class. So we'll be dealing with these are the few terminologies that we will be dealing with today. That is your history. So these are the few terminologies we'll be dealing with today. I'm sorry, I'm just checking my internet because yesterday it was a huge problem. So I just want to make sure that I'm I'm actually streaming. So history, terminology, why capnography, physics, types, basic physiology, components of capnography, clinical application, and carry on. So this is how capnography will be covered, but it will be covered in 2 parts. Don't worry, I'm not going to cover this like in this entire thing today. I'll be covering it in 2 parts. So now we shall move on. So coming to the history now. So Luft said that carbon dioxide absorbs infrared light. Ramwell proved it beyond doubt. In 1978, Holland, was the first country to adopt capnography, and in 1999, so in 1999, so 1999 is when the ISA said that capnography basically has to be part of a standard of monitoring, part of the standard of monitoring. So the ISA decreed various monitoring standards and the capnography was an important part. They said that capnography has to be a part of this monitoring. So coming to the terminologies, we have capnometry, capnometer, capnogram, capnography. So the ASA guidelines for the anesthetic monitoring stated that, so ASA is American Society of Anesthesiologists. So their guideline states that when a tracheal tube or supraglottic airway device is inserted, its correct position must be verified by identifying carbon dioxide in the expired gas. Okay, and continual carbon dioxide end tidal carbon dioxide monitoring analysis shall be performed until the device is removed or the patient is transferred to a post-operative care unit. Okay, and in 2005 an audible alarm was added to this monitoring standard. So in 1999 Indian Society of Anesthesiologists said it has to be a part of everything. So the American Society of Anesthesiologists basically said that whenever uh, for basic anesthetic monitoring, when a tracheal tube or a supraglottic is basically your laryngeal mask airway and all that, that is like the tracheal tube. It is a device which sits over the larynx. It does not pass through the vocal cords. So whenever supraglottic device or a tracheal tube is inserted in a patient, the correct positioning of this tube has to be, so basically the correct positioning of tracheal tube and supraglottic airway device has to be done by end-tidal carbon dioxide monitoring, and this monitoring has to continue till removal of this airway device. Okay, and in 2005 an alarm was added to this monitoring. Okay, so any disconnection etc, to know the alarm was added. Now what is capnometry? So capnometry is a measurement of carbon dioxide in a mixture. So capnometry is basically the measurement of carbon dioxide in a mixture. Capnometer, just a sec. Capnometer is basically a device that performs the measurement. So capnometer performs measurement. Okay, capnometer performs measurement. Capnometer basically performs the measurement. Okay, then we come to your capnography. Is basically the recording of carbon dioxide concentration versus time. So the recording of carbon dioxide concentration versus time. Your capnogram is the actual waveform. Okay, and okay, so and your capnogram are the same thing. Okay, so basically, so capnometry is the measurement of carbon dioxide in a mixture. Capnometer is the device which performs this measurement. Capnography is basically the carbon dioxide concentration versus time, and capnogram and capnograph basically are these two are actually both these are the actual waveform that is produced. Now a capnometer, okay, your capnometer, this capnometer. So this capnometer, there are certain standards, okay, that have to be followed for this capnometer. So the carbon dioxide reading shall be within plus or minus 12 of the actual value. So first is the carbon dioxide reading has to be within plus or minus 12% of the actual value, or plus or minus basically, or plus or minus 4 millimeter of mercury. So this can be the variation. So it has to be uh, plus or minus 4 of the actual measurement. Then the manufacturer must disclose any interference any interference must be disclosed by the manufacturer. Any interference should be disclosed. Okay, so any interference should be disclosed. Basically, interference is basically with ethanol, helium, dichlorofluoromethane that is produced basically by the inhalation agent. So any interference should be disclosed. It must have a high alarm. Okay, alarm for both high carbon dioxide as well as high inspired as well as expired carbon dioxide. So basically, it should have alarm for both high and low. Okay, so alarm, there should be alarms. Okay, alarms for both high and low carbon dioxide. Okay, so there should be alarms for high carbon dioxide as well as low carbon dioxide, and any interference should be disclosed by the manufacturer. And the carbon dioxide variability, basically should be within plus or minus 4 millimeter of mercury. So this is the basic standards for capnometry. Now oxygenation. Okay, so oxygenation is measured by pulse oximetry. Sorry. Oxygenation is measured by pulse oximetry. Okay, it is non-invasive measurement. It measures the percentage of oxygen in your red blood cells. Any changes in ventilation can take minutes to be detected, so there can be some lag. So any changes in ventilation, the oxygenation might take the pulse oximeter might take minutes to detect. It is affected by motion, poor perfusion, and some dysarrhythmias. So any cardiac arrhythmias, poor perfusion, so it will not read correctly, it will not show a correct value. Any artifacts like especially movement and all that, or if there is nail polish on the fingernail, such artifacts will disrupt the pulse oximeter reading. Whereas your capnography, it provides information about carbon dioxide production, pulmonary perfusion, alveolar ventilation, respiratory patterns, and elimination of carbon dioxide from the anesthesia circuit and ventilator. So, it provides information about carbon dioxide production, 2 pulmonary perfusion, 3 alveolar ventilation, 4 respiratory patterns, 5 is elimination of carbon dioxide from the circuit. So this is the information that is provided by your capnography. So basically your carbon dioxide monitoring is the capnometry detects your carbon dioxide. It can detect airway obstruction, extubation, and so see, now with your pulse oximetry, like we discussed, if there's nail polish or any movement, etc., it will disrupt. But capnometry will not get disrupted because the capnometer is not in contact with the patient, right? It's part of the tubing of the patient. We'll come to that, I'll show you all. So it's not really part of the patient, so it does not get disrupted by such artifacts. Plus, it is not disrupted by cardiac arrhythmias. Such artifacts do not, and of course within 10 seconds it is detected, whereas your pulse oximetry, like they said, few minutes change in ventilation will show in a few minutes, whereas with your capnometry your change in ventilation will be seen within 10 seconds. So it is measured by end tidal, so ventilation measured by end tidal carbon dioxide, basically your EtCO2, okay, your end tidal carbon dioxide. So partial pressure, it is measured as partial pressure or volume percentage of carbon dioxide in the airway at the end of exhalation. So the carbon dioxide is measured, the EtCO2 is measured as partial pressure or volume percentage of carbon dioxide in the airway at the end of expiration. But this volume percent is not often used. Okay, we mostly use partial pressure. This method of measurement is not often used. We generally use this partial pressure measurement. So breath to breath measurement provides information within seconds. Like I told you, there is no delay. Unlike with your pulse oximetry, it is not affected by motion, artifacts. So no motion, nail polish, it is not affected by that. Poor perfusion or dysarrhythmia. The reading will be continuous, unlike your pulse oximeter. Pulse oximeter is a small device which is put on the finger. The capnometer is basically a device which is connected between the endotracheal tube, which is in the patient. So between the patient, the endotracheal tube, which is the patient end, one end of the endotracheal tube is in the patient, the other end will be connected to the anesthesia circuit. So one end of the carbon dioxide monitor is towards the patient and one end is towards the circuit. So basically between the endotracheal tube and the patient end it is, and the machine end, it is connected. Now some differences between oxygenation and ventilation. So oxygen is for metabolism. SpO2 measures percentage of oxygen in the RBC. Okay. Reflects changes in oxygenation within 5 minutes. So like I said, this gap, whereas ventilation, carbon dioxide is metabolism. So ventilation, EtCO2 measures the exhaled carbon dioxide and reflects changes in ventilation within 10 seconds. This is what we discussed, right? Okay. Now, why do we need capnography? So basically, it is an indirect monitor which helps in differential diagnosis of hypoxia. So why do we need this capno? One is, apart from the ASA saying that it has to be a mode of monitoring for us, right? So it is a very essential part of monitoring. So apart from that, why do we need it? So basically, the it is an indirect monitor. It helps in differential diagnosis of hypoxia to enable measures to be taken before hypoxia results in brain damage. Like your pulse oximeter, this also helps in your diagnosis of hypoxia. Now, capnography has been shown to be very effective in the early detection of adverse respiratory events. So basically, your airway obstruction, your tube disconnections, pulmonary embolism, okay, any machine related problems. So all effects on the patient. So your capnography is all these adverse events. Now, capnography and pulse oximetry, when applied together, have helped in the prevention of 93% of avoidable anesthesia mishaps, according to ASA claimed close study. So the ASA has done a study which showed that when used together, capnography and pulse oximetry, it prevented 93% mishaps which could have occurred. Now, capnography has also been shown to facilitate better detection of life-threatening problems than clinical judgment alone. So then clinical judgment alone, it has been shown to be sometimes more effective, but clinical judgment is equally very, very important. Now, why measure ventilation in non-intubated patients? When the patient is, okay, fine. Right now, we have been saying that, ASA has said that we have to measure ventilation in intubated patients. So, why do we have to measure in non-intubated patients? When these patients are not intubated, why should we measure in them? So, basically, to assess acute respiratory disorders like COPD and asthma. Okay, so you can gauge the response to treatment. So basically, prior to administering, like in asthma patients, the capnometer will have a shark fin pattern, like, the graph will be like this, like a shark fin pattern. We'll be dealing with this tomorrow, the graphs of the various diseases. So after, this is in asthma. So this is prior to the installation of medication. So after bronchodilation, after bronchodilator is given, the graph will be normal, right? This is a normal graph. So the shark fin pattern will go. So basically, non-intubated patients to gauge the response to treatment. So why measure? So now to gauge the severity of hypoventilated states. So drug intoxication, congestive heart failure, sedation and analgesia, stroke, head injury. Basically, to detect hypoventilation again by the graph. Okay, the graph will be much smaller like this. Okay, we will come to that tomorrow. I will explain it to you. So in these, so gauge in the so when hypoventilation, if you see hypoventilation, you can always think of one of these problems that may be present there, which is causing this, to assess perfusion states and non-invasive monitoring of patients in DKA. Now coming to carbon dioxide transport. So carbon dioxide transport, 60% is as bicarbonate ion. Okay, in the body. Okay, this is in the body. 60% of carbon dioxide is as bicarbonate ion. This is actually important for you all to remember how carbon dioxide exists. I'm just telling you all in brief. This will be dealt for you all in physiology. 10 to 20% binds to the amino group of proteins, mostly hemoglobin. So 10 to 20% binds to hemoglobin. This is your Haldane effect. And 5 to 10% is directly dissolved in plasma. So this 5 to 10% in plasma, 10 to 20% hemoglobin, 60% as bicarb ions. Now, how is this end-tidal EtCO2 produced? So basically, from your right ventricle, blood enters, which contains carbon dioxide. Ventilation, this is your lungs. Exchange occurs and oxygen leaves to the left atrium. Okay, so carbon dioxide can be measured. These are the various methods of measuring carbon dioxide. So arterial blood gas, that is your PaCO2, is 35 to 45 millimeter of mercury. This is your PaCO2, 35 to 45 millimeter of mercury. Mixed venous blood gas, PeCO2, 46 to 48 millimeter of mercury. Your EtCO2, exhaled carbon dioxide, this is what is measured by capnography. Right? So this is what is measured by capnography. This is 35 to 45 millimeter of mercury. So this is similar to this, but this EtCO2 actually is approximately 4 to 5 millimeter of mercury less than PaCO2. Okay, so if your EtCO2 on the monitor, if your EtCO2 is actually showing 45, you can expect it PaCO2 to be 49, right? So your this EtCO2 is around 4 to 5 millimeter of mercury, slightly less than your PaCO2. This is another important point that you all need to remember. So end-tidal carbon dioxide. So your end-tidal carbon dioxide, it basically reflects changes in ventilation, movement of air in and out of the lungs, diffusion, exchange of gases between the air-filled alveoli and the pulmonary circulation, and perfusion, circulation of blood. So it actually reflects changes in all three: your ventilation, diffusion, and your perfusion. So any mismatch in these will be reflected on your EtCO2 by change in the waveform. So monitor changes. So when you see the change in the waveform, so if there is asthma, COPD, airway edema, foreign body stroke, it's basically indicating a change in ventilation. Your pulmonary edema, alveolar damage, carbon monoxide poisoning, smoke inhalation indicates a deficiency with diffusion, and your shock, pulmonary emboli, cardiac arrest, and severe dysarrhythmias indicate a problem with perfusion. So the arterial to alveolar difference for carbon dioxide, this is a patient with healthy lungs. So when there is a wider difference, okay, so when your alveolar, basically when your alveolar arterial gradient is elevated, so in abnormal perfusion and ventilation, incomplete alveolar venting, empty, and poor sampling. When do you have a decreased alveolar arterial gradient is basically in pregnancy. I'm sorry. So basically in pregnancy, infants and children bypass after coming off cardiac bypass, low frequency high, so basically low frequency high tidal volume ventilation, that is increased respiratory rate, pregnancy, infants and children, you will have a decreased EtCO2. Okay. So basically now your that alveolar arterial gradient that we spoke about, yeah, sure. So so end-tidal carbon dioxide is usually, like I said, usually lower than your PaCO2, that we have always anyways already discussed that. right? So it is basically lower than your EtCO2. Um, so problems with sampling of accurate measurement is difficult with high ventilatory. So whenever there is a high ventilation, okay, uh, so increased respiratory rate and all, there will be problems in sampling. So there can be a lot of sampling errors that can occur with this EtCO2, right? So a lot of sampling errors can cause a increase or decrease in your EtCO2. So now, where all can these sampling errors occur? Okay, so the sampling error can occur. One is at where the HME filter. So at the HME filter, there is a small port where this EtCO2 can be, this gas sampling line can be attached. So basically, uh, when this gas sampling line is placed, it is usually placed on the machine side of the HME to avoid contamination and waterlogging. Okay, so this can result. So basically, the from the patient. So this is the patient. So the ET tube comes, and over here there will be an HME filter. Okay, there will be a filter. So the gases are coming from the patient, entering the filter, and the carbon dioxide monitoring device will be placed here. Okay, this is your side stream. This is your carbon dioxide monitor, and it is, of course, it is part of the endotracheal tube. This is your anesthesia machine, and this is your circuit connecting to the anesthesia. So this is your circuit connecting to the anesthesia machine. This is your filter, and this is your carbon dioxide monitoring. So it is placed after the filter. So what happens is all the secretions that are coming from the patient first get waterlogged in the filter. They collect in the filter. So this can cause error in the readings. Okay. Then another source is if it is placed here before the patient, I mean before the HME filter also, there can be some leak over here from the endotracheal tube. So in spontaneously breathing patients, there's a poor correlation between this end-tidal carbon dioxide and arterial carbon dioxide. This AA gradient is not very reliable in spontaneously breathing uh, uh, patients. Okay, so because they might be breathing slowly, or there might be some airway obstruction, so it's very difficult to really know whether the patient is sedated or not in a spontaneously breathing patient. So this end-tidal carbon dioxide is a poor correlator in spontaneously breathing patients. Then what, even changes in body position. Okay, changes in body position can change this end-tidal carbon dioxide and norm gradient. Okay, like lateral prone position, etc., can cause changes. So and then, so it can cause sampling error again. Then any capnometer problem. So if there is any break in the capnometer, etc., it can cause erroneous readings. Then of course, this to drugs. So any patient taking acetazolamide can cause changes in basically changes in PaCO2 and the EtCO2. So it can cause a discrepancy. It basically it causes decrease in the EtCO2. So acetazolamide decreases EtCO2 as compared to the PaCO2. Okay. This is because it absorbs bicarb, so there is less carbon dioxide available. Okay, so acetazolamide actually causes a decrease in EtCO2. Then again, temperature also will affect. So hypothermia increases the arterial to end alveolar this gradient. The arterial to basically increases the AA gradient. So the arterial to alveolar gradient is increased with hypothermia. Now Raman effect. So this was how what capnometry is basically uh, based on. Okay, so this is what it is actually based on. So coming to the Raman effect, so electromagnetic radiation and molecule, it consists of basically those are the two terms that are involved in the Raman effect. So the Raman effect says that the transfer of energy affects the vibration energy associated with bonds between the atoms in a molecule. So there are bonds between atoms in a molecule which vibrate. So the transfer of energy will affect the vibration of these bonds. So absorption of radiation at a particular wavelength is associated with a specific type of bond between atoms in a molecule. So depending on the bond between the atoms, there will be absorption of radiation particular wavelengths. Okay. So here absorption of radiation depends upon the wavelength of radiation, and this in turn depends on the bonds between the molecule. Okay, so basically your carbon dioxide, nitrous oxide and anesthetic agents are the ones which absorb infrared radiation. Your oxygen does not absorb infrared radiation. So you cannot monitor oxygen with this infrared radiation. Carbon dioxide, nitrous oxide and inhalation agents are monitored. So energy of radiation is proportional to the frequency of radiation, and the transfer of energy between radiation and molecule results in a change in wavelength of radiation. So the transfer of energy between the radiation and the molecule results in change in wavelength of the radiation. Now Raman spectrography uses the principle of Raman. So this carbon dioxide measurement basically uses the principle of Raman scattering. So the gas sample is aspirated into an analyzing chamber where the sample is illuminated by a high intensity monochromatic argon laser. So basically from the patient, the gas sample is aspirated into a small chamber where an infrared light basically from a monochromatic argon laser illuminates it. The light is absorbed by molecules which are then excited to unstable vibrations and rotational energy. This is Raman scattering. So basically from the patient, a sample of the gas is aspirated. This is continuously happening. So the sample of gas is aspirated. It goes into a small chamber where it gets illuminated by this high intensity monochromatic argon laser, basically by infrared light coming from this laser. The light gets absorbed by these molecules which are so the light gets absorbed by these molecules which are excited, in the sense they vibrate and rotational energy is generated, and these signals are then transmitted to the at right angles to the laser beam, and then they are measured, right? So basically the way they the Raman scattering signals, basically this Raman light, they're low intensity and are measured at right angles to the laser beam. So the laser beam is continuously coming, these molecules are rotating, and there is a photo detector here. So the way they rotate at right angles to this laser beam, so the way they rotate, it will generate a pattern over here, and based on the type of pattern that it generates over here, the gases can be detected. Okay. This is basically mostly for your inhalation agents. Okay. So the spectrum of Raman scattering lights can be used to identify the type of molecule in the gas phase. This is the same Raman spectrography. Just a sec. Okay. Now we will come to your. Now this is the infrared. The measurement of respiratory gases. So how is this measurement done? Basically this infrared technology. So this infrared analysis, basically infrared analyzers are based on the principle that gases with two or more dissimilar atoms in the molecule, like carbon dioxide and nitrous oxide, have unique and specific infrared light absorption. So basically, it says that the infrared analysis says that various gases like your carbon dioxide and nitrous oxide, right, they have unique infrared, so they absorb infrared light at different spectra. Okay, it's unique to each of them. Okay, so it absorbs infrared light uh, at different absorption, unique infrared light absorption spectra. So since the amount of light absorbed is proportional to the molecules, the concentration of the molecules, of the absorbing molecules, the concentration can be determined by comparing the infrared light absorbance in the sample with that of a known standard. So the amount absorbed by these gases is basically directly proportional to the concentration of the gas. Okay, so this is your next point. So it is directly proportional to the concentration of gas. So so basically so that the amount absorbed by these gases, amount of infrared light absorbed, is directly proportional to the concentration of the gas. So by comparing the infrared light that is absorbed, we can know the amount that is absorbed, we can know which gas is present. So that is how it is measured. Okay, so non-polar molecules like your nitrogen, argon, oxygen, helium, xenon, they do not absorb infrared light, that I have already told also. Your helium, argon, oxygen, xenon, nitrogen do not absorb xenon, they do not absorb infrared, and they cannot be measured by this infrared technology. Okay, this method cannot remove the radiation that falls between absorbing lines because of continuous emission that is occurring. Okay, it's okay, leave that. Okay, so most of the units that are in use today, most of these infrared measurements that are in use today, recognize the agent that can be monitored with this technology. Okay, so after the sensor detects the infrared energy, an electrical signal is produced, amplified, and concentration is displayed. Okay, so basically the analyzer selects, so there is an infrared analyzer, so the analyzer selects the appropriate infrared wavelength using a filter to maximize the absorption of the second selected gas at its peak wavelength. So this an analyzer, sorry, analyzer, so there is an analyzer, so the analyzer will selects the infrared wavelength. Okay, then so the analyzer will select the infrared wavelength, and most units used today can recognize the agent that is fed in. Okay, so the purpose of the analyzer is to recognize the infrared wavelength, and this will then be displayed. So basically, what are the advantages of this? So the infrared analyzers can be of two types: your mainstream analyzers and side stream analyzers. Okay, so two types of analyzers, mainstream and side stream. Your mainstream is basically, so your mainstream analyzer is basically, it will be in line with the patient and the machine. Okay, your analyzer as well as the capnometer all will be in line. Your side stream analyzer, basically, uh, that is what I spoke to you all about, right? A sample will be aspirated, and will be taken to the analyzer. Okay, I'll be discussing that further. Okay, now what are the advantages of this? See, I'm sorry. What are the advantages? What are the advantages of this infrared technology? So this basically the mainstream and your side stream analyzers. What are the advantages and disadvantages? So basically your advantages are uh, so infrared analyzers are capable of, they are multi-gas analyzers. Okay, multi-gas analyzers. So basically, they are capable of measuring your carbon dioxide, uh, nitrous oxide, and all of the commonly used potent volatile anesthetics. So basically, your carbon dioxide, nitrous oxide, and your halogenated agents. Basically, your inhaled anesthetics, but it cannot measure your non-polar gases such as oxygen, xenon, helium, nitrogen. Right? Remember that. Then volatile agent detection, uh, it is able to detect the particular volatile agent. So volatile agent detection. So there are two types in the mainstream. There is monochromatic analyzers as well as polychromatic. So monochromatic cannot really differentiate between the volatile agent and they are little dangerous to use. Whereas your polychromatic can differentiate between the volatile agent. That's not required. That is just the type of analyzers, right? Then there is no need to scavenge gases after measurement. No need of scavenging. So whenever during anesthesia, whenever gases are provided to the patient, they have to be scavenged, right? The expired gases have to be scavenged. Otherwise, everyone, if the patient suppose has an infectious disease, everyone in the operation theatre can get it. Everyone is exposed to that infectious disease, right? So every operation theatre has something known as a scavenging system. So whatever is expired by the patient, so the ventilator is delivering a breath to the patient. Whatever is expired by the patient is taken up by the scavenging system. The scavenging system is a different system, but it's inbuilt with the ventilator. Okay, so that is taken up by the scavenging system. So, but this is a small amount of gas that is aspirated. There is no need of scavenging system separately for this because the gas which is analyzed is given back to the ventilator and automatically goes to the scavenging system, right? So there is no need of a scavenging system. Easy portability. So these are very tiny, these analyzers, these carbon dioxide, they are very tiny. Okay, these analyzers are very tiny, so it's very easy. They are not heavy, they are tiny, compact, lightweight. Okay, so portability, lightweight, compact, and they can easily be incorporated into the anesthesia monitor machine. Okay, they're not causing any burden. Okay, no dead space, nothing. And of course, quick response time, they have a quick response time. So they have a quick response time. It's fast enough to measure, basically the response is fast enough to measure inhaled as well as exhaled concentrations and deliver a graph. And it also has a short warm up time. So you don't have to keep this instrument in standby mode, thinking that if I switch it off, then it will take very long to come back. No, there is no need to keep the instrument in standby mode because the warm up time is very short. Okay. Oh, I'm sorry guys, I don't know what happened. My screen went blank, I'm sorry. So it has a very short warm-up time, right? So the warm-up time is very short. There is no it doesn't take very long. So the warm-up time is, it has a short warm-up time. Okay, so short warm-up time. There's no need to keep it in standby mode. Then calibration is very easy. So with the older models, it required a complicated calibration, but with the newer models, it only requires periodic calibration. So older models, calibration was required like practically every day, but here only periodic calibration is actually needed. You do not, the calibration is not required at all times. Just periodic calibration is more than enough. And of course, the lack of interference at all times, the lack of interference by other gases. There is no interference, so basically there is lack of interference by other gases. And it is also very useful in detecting the volatile anesthetic breakdown products. Okay, so your volatile anesthetic breakdown products that are seen with sevoflurane, halothane and all that can be detected. So basically when how it detects is, so when there is a breakdown product of the volatile anesthetic, these infrared analyzers, so even though you have put on suppose there is a breakdown product of desflurane, so even though you have this breakdown of these products occurs only when carbon dioxide concentration in the carbon dioxide absorbers is like very high and they are desiccated, basically dry. The heat is hypothermic reaction is occurring, which is very rare. That is only when faulty carbon dioxide absorbents are used, but otherwise it does not occur. So basically whenever these byproducts are produced in excess quantity, these volatile anesthetic, so whatever is set, these infrared analyzers, basically whatever these carbon dioxide analyzers, so if desflurane is set on the dial, basically a desflurane vaporizer is being used, these carbon dioxide analyzers will indicate that a different vaporizer is in use. So that is a detection, that is a early sign that there is a breakdown product and the patient can be in danger. Okay, now what are the disadvantages is basically uh, oxygen is not absorbed by infrared light. Okay, it causes broadening of the carbon dioxide. So when oxygen is being given, oxygen can decrease the carbon dioxide curve, right? So it can decrease the carbon dioxide curve. So this oxygen can decrease the carbon dioxide curve. Then there's some overlap of carbon dioxide and nitrous infrared. So there is some overlap. So there can be some erroneous readings. Overlap in the carbon dioxide and nitrous oxide readings. There is some overlap. Okay, there is some overlap. And if the analyzer is set to measure volatile agents from uh, different from that is present in the mixture being analyzed, it won't be. So these are basically in analyzers which you need to set the agent that is being monitored. If you switch the agent, it will not detect that agent. Okay, now if there is any interference, like basically substance like ethanol, methanol, dimethyl ether, acetaldehyde or acetone, they can cause high volatile agent readings. Okay, so this is basically when a volatile agent is being used, not carbon dioxide, but these analyzers also help to detect volatile agents. So when a volatile agent is being used, they can show high reading if there is some interference, basically some contamination with ethanol, ether, methanol, okay, methane, etc. So with rapid respiratory rate, so basically there are more advantages as such than the disadvantages. So now your rapid respiratory rate and the response time may be slow to measure. So again, the rapid respiratory rate, you will get a decreased reading, okay, because there might not be enough response time to measure. Then any radio frequency interference also can lead to erroneous readings. So radio frequency interference, and like I said, it's difficult to add newer newer volatile anesthetic agents. Now coming to your side stream optical infrared analyzer. Okay, this is basically your side stream capnometer. Okay, so your side stream, it is also known as diverting. So side stream is also known as diverting. Okay, it is also known as diverting infrared analyzer. Okay, so infrared light, so the infrared light is continuously focused on, so this is the infrared light is continuously focused on a spinning chopper wheel. So this is your spinning chopper wheel. So infrared light is continuously focused on a on a spinning chopper wheel. The wheel has holes with filters specially selected for gases to be measured. So this chopper wheel has holes with filters which are specific for gases to be measured. So they are specifically selected for gases to be measured. Then the gas to be measured is pumped continuously through a measuring chamber. So it is the gas to be measured is pumped continuously through this measuring chamber. The filtered and pulsed light is passed through the sample chamber and also through a reference chamber with no absorption characteristics. So from here, your sample chamber, your light is entering, your your air is entering, sample air, and after passing through the filters, the light is passing through this sample chamber as well as reference chamber. These chambers have no absorption characteristics. So both these chambers, they have no absorption characteristics. Okay, so they have no absorption characteristics. So from here your sample is coming, from here the filtered light, infrared light is coming, passing through the reference chamber as well as the sample chamber. The light is then focused on an infrared photosensor. So this light is focused on this infrared photosensor. The amount of light absorbed by the sample gas is proportional to the partial pressures of gases whose infrared light absorption. So basically the amount of light, so the amount of light absorbed by the sample light, so basically the amount of infrared light absorbed by the sample light is directly proportional. So it is directly proportional to the partial pressure of gases whose infrared light absorption patterns correspond to the wheel. Is directly proportional to the partial pressure of the gases that are absorbed by this wheel. So the gas that is basically the filter that is kept here, the gas that is absorbed. So the amount of light absorbed by this sample gas will be directly proportional to the partial pressure of the gas whose infrared light absorption pattern. So the infrared light absorption pattern of this corresponds to the filter in the wheel. Okay, you all got it? Okay. Then the changing light levels on the photosensor produce, so basically this, there will be changing light levels. There is electrical current passing through this. Okay, so there is electrical current. So basically through this photosensor, this electrical current is passing. So this changing in the light produces changes in the electrical current that is running through it, producing your waveform on display. So this is how your side stream infrared analyzer will work. So this is your side stream. This is your sensor and display. This is your circuit. This is where the sampling adapter is. This is your ET tube that is coming basically from the patient. So from here the sampling gas. This is where your sampling. So sorry. So basically it is side stream, right? I told you all it is side stream. So from here it will enter, the gas will enter like this. The sample will be taken here 6 feet away. This is your sensor and display, and inside your sensor or this will occur. The infrared light will, there are two chambers, reference chamber and sample chamber, and what we just discovered, and this is your display. Now advantages and disadvantages of your side stream. So it is very easy to connect, no problems with sterilization, can be used in awake patients. It just has to be attached to the face mask or the nasal prongs. It is easy to use when patient is in usual position such as prone. So in whichever position the patient is, it is very easy to use. It just has to be connected to the oxygen mask or the nasal prong in awake patients. And of course in intubated patients, it is connected after the EP tube, after the filter. So it can be used in collaboration with simultaneous oxygen administration via nasal prong. So even though oxygen is being administered, it can be used. However, because the oxygen is not absorbed, it can decrease the waveform. So oxygen can have some interference. The disadvantages are there is a delay in recording due to movement of gases from the ET tube to the unit. So there can be some delay, but it is not very big delay. It is not a very significant delay. Basically, there can be sample tube obstruction. Now that is a problem which can actually occur. So the sample tube obstruction can occur. So this sample tube obstruction basically is so like I said, it is placed after the filter, right? So if any, the secretions clog the filter, this tube can get obstructed, then there will be no reading. Then you might think that, oh, it is disconnected. Any small cuts in the sample tube, so it is a very thin tube, so any small cuts also, you will get a erroneous reading. You will not be able to find a reading. The capnography, the reading might be reduced and you will think that there is something wrong. Then water vapor pressure changes affect carbon dioxide concentration. So water vapor pressure changes affect carbon dioxide concentration. So this has to be corrected for, so basically these analyzers have to be corrected for atmospheric pressure and water pressure. It has to be corrected because it causes changes. Then pressure drop along the sampling tube affects carbon dioxide measurements. So basically any pressure drop will affect. Now coming to mainstream optical infrared analyzer. Okay. Basically mainstream is your non-diverting. It is also known as your non-diverting analyzer. So non-diverting analyzer. Okay. Now your non-diverting analyzer is so this is how it is. This is basically your, so I'll tell you. So the gas stream passes through a chamber. This is your cuvette, which is the chamber. So cuvette. So gas stream passes through cuvette. So the gas stream passes through the chamber, which is your cuvette, and with two windows that are transparent. So this cuvette, okay, as you can, so under this there are two windows. Okay, so it is a tube like this. So there is one in window here and one is exactly adjacent opposite to this. So this surface will have one window, and the surface below this surface here will have another window exactly adjacent to it. Okay. So it has two windows that are transparent to infrared light. So this cuvette has two windows which are transparent to infrared light. Yeah, it allows infrared light to pass. So the cuvette is placed between the breathing system and the patient. So one end is to the patient, one end is to the breathing. So one end is to the breathing system and one end is kept to the patient. Okay. The sensor which houses both the light source and the detector fits over the cuvette. So this is the sensor which has both the light source and detector. Okay, it has a light source as well as the detector. Then to prevent condensation, basically because of water vapor, the sensor is basically heated slightly above body temperature. It is inbuilt. Okay, infrared light shines through the window one side of the adapter and the sensor receives the light on the opposite side. So from here infrared light shines through one window, basically the cuvette's window through one window, and the sensor receives it on the other side. Okay, so the sensor will receive it on the opposite side. So after passing through the sample chamber, the light goes, so basically after it passes through the sampling chamber, the light goes through a rotating wheel which has three ports. Okay, one port has carbon dioxide concentration, then the other chamber is vented to the sensor's internal atmosphere, and it also has a cell with nitrogen. So the gas is basically passes through three cells. One contains nitrogen, one carbon dioxide, and one is adjusted to the sensors to internal atmosphere of the sensor. The radiation then passes through a filter that screens the light to the correct wavelength and displays it. So basically the the light source is here, the detector is also here. The light source passes through three ports, and then it goes through a filter which corrects it, which has a particular wavelength. It corrects it to that wavelength and then displays it. So this is your mainstream, this is your infrared, this is the infrared source, this is the infrared detector, and this is your display. So basically from the patient, this is from the patient. Okay, it's this is going to the machine over here. This is the machine end. So these two Y ports go to the machine. So here the sensor will be kept here. This is your cuvette. Basically this is your analyzer, which has a sensor as well as the detector, the light source as well as the detector. So the light source passes through a rotating wheel which has three ports. Then it comes on to a filter which detects the correct gas and it displays. So some of the advantages are: no sampling tube is required. There is no obstruction that can occur with this because there is no side tube. Because there is no sampling tube, hence no obstruction. No effect due to pressure drops. No effect due to changes in water vapor because there is no accumulation of water vapor. No pollution. No deformity due to dispersion of gases, and no delay in recording, and suitable for neonates and children. So the sampling tube, there is no sampling tube, so there cannot be any delay in recording. However, these are very heavy. These are little heavy sensors and can cause weight on the traction on the endotracheal tube. So these sensors are heavy, causing traction on the endotracheal tube. They have a long electrical cord which can get entangled and can cause, because of that entangling, the entire ET tube can come out because it is attached to it and it is heavy. The sensor window may clog with secretions, but this can be replaced, and it is difficult to use in unusual patient positions, especially like prone, because this is very heavy. So in the prone position it will hang and it might cause the endotracheal tube to get dislodged. Okay, so this is basically your mainstream and side stream. So endotracheal tube to patient. This is the sampling adapter. This is the sampling tube. So a sample will be taken from here to the sensor and the display unit, which is located away. So because of this tube, they can be kinking, they can be cutting, they can be clogging of this tube, and hence, and also there can be a delay. So for those reasons, that is why uh, but however it is lightweight, there is no traction, it can be used in prone positions, right? However, this is it has a cuvette. So this is the cuvette, this is your sensor, which contains the infrared source as well as the infrared detector. So the gas coming through will pass through the cuvette, so this is your cuvette, right? So I told you the cuvette has two windows. The cuvette has two windows, so one window is here, one window is here. So the infrared light passes through the window. The cuvette allows the infrared light to pass, and it passes through filters which have three ports, one for oxygen, carbon dioxide, nitrogen, and the other is the sensor is adjusted to atmospheric. The internal atmosphere passes through, and the filters are located on the detector, which detects the appropriate wavelength, what is absorbed by the light or by the air that is passing through and then this is displayed over here, the correct gas. So but what is the disadvantage of this? The disadvantages of this is, so there is no clogging. Of course the sensor can get clogged with water vapor, but it can be replaced and cleaned very easily. There is no lag time because it is located in line with the gases that are going to the ventilator, so there is no lag. There can be no so basically no disconnections can occur because there is no sample tube, so there is no complications that are associated with the sample tube, like obstruction and pressure drops, then changes due to water vapor, because nothing is clogging it. Of course sometimes, like I said, the sensor can get clogged with water vapor. There is no loss of gases because over here, if there is a small in this basically in this one, if there is a sorry, in the side stream, if there is a small rent here, there can be release of gases. Over here there is no loss of gases. uh, but however this is heavy. What is the problem with this is bulky, the weight, right? It is bulky, and because of the bulky nature, it cannot be used in prone positions. Yeah, it is bulky, it can cause disconnections, cannot be used in prone position. The entire tube hangs, so it can cause hinking of the endotracheal tube, increase in airway pressure, and can be quite disastrous. Now coming to the chemical method of carbon dioxide detection, basically a pH sensitive chemical detector. So this pH sensitive, first I'll tell you all the advantages and disadvantages of this I'm sorry, this yeah, we've already discussed the advantages, disadvantages, I'm sorry. However, so the some more advantages are they, so the mainstream, basically they have a faster response time. There's no delay time, like we discussed. No gas is removed from the breathing system, so no scavenging is required even with this. Water secretions are seldom a problem with this type of analyzer. Okay, although on the cuvette window there can be some secretions that can be clean. Then sample contamination by fresh gas is less likely. So with the diverting monitor, sample contamination with fresh gas can occur. So with this side stream analyzer, there can be contamination with oxygen. Okay, with oxygen there can be contamination, which will decrease your EtCO2 curve basically. Then in this monitor, basically there's fewer disposable items. Okay, nothing much to dispose in this, so it is more economical also. Now disadvantages are, this has to be placed near the patient, and because first of all it is so heavy, so because of to obtain an accurate reading, it has to be placed near the patient and because of its bulky nature, can cause kinking of the tube. Then it increases dead space. So the adapter between the patient and the breathing system increases dead space because it is bulky. That the side stream is very tiny, right? It's just a small sampling tube, so it doesn't really change the dead space. However, this is an important point. The mainstream will increase the dead space. So increase in the dead space. Then leaks, disconnection circuit that can occur. So with mainstream carbon dioxide, condensed water secretions or blood on the window of the cuvette can interfere, that we discussed. The sensor may become dislodged. So yeah, because of the bulk, the sensor, if it becomes dislodged from the cuvette, no waveform will be seen at all. Even slightly dislodged, incorrect reading may be got even though the waveform appears. So if it is completely dislodged, there will be no waveform, and slightly dislodged, you might get a waveform, but it will be wrong. Then the sensor that has to be replaced if damage occurs is really expensive. And the mainstream monitor can measure only carbon dioxide and oxygen. It does measure oxygen too. uh, the adapter for this sensor has to be cleaned and disinfected between uses because secretions go into it. So it has to be because there is a potential for cross infection, so it has to be disinfected. And in some patients, thermal burns have been reported despite use of multiple layers of gauze pieces which were kept between the sensor and direct contact from the skin. uh, Hence, to prevent this, but burns have been noted maybe in some where the sometimes when they're doing face and head and neck surgeries, the endotracheal tube has to be put, it cannot be kept by this side, it has to be brought down along the length of the patient. So maybe at that point contact could have caused thermal burns. To prevent this, it is necessary to put a piece of aluminium foil between the two pieces of material, basically between the skin and the analyzer. All right. um, with the side stream, the accuracy actually decreases with an increasing respiratory rate, and no longer the sampling is not effective anymore. uh, Basically the sampling flow rate should be proportional to the size of the patient for the side stream. Excuse me. Now coming to the chemical methods of detection of basically the chemical method of detection of this carbon dioxide. This is known as that calorimeter, which is a pH sensitive and it changes according to the pH, right? So chemical method of carbon dioxide detection. So basically the technology, it is basically the technology that is used is basically hygroscopic carbon dioxide. So basically it is a hygroscopic carbon dioxide detector. So it basically contains hygroscopic paper that is impregnated, hygroscopic paper that basically has a colorless base, and an indicator which changes color based on pH. Yeah, so it is basically this. Inside there is a hygroscopic paper which changes color based on pH. So change the thing off. Okay, so it's basically hygroscopic technology. Okay, the filter paper is visible through a clear window, and the color chart on the dome was designed to be read under fluorescent light. So this color chart was actually designed to be read under fluorescent light. So this is the window through which the filter paper can be seen, and this was designed to be read under fluorescent light. Okay, there is another auxiliary color chart that is included in each package. if lighting is not fluorescent. So there is a color chart in each package. So a purple or mauve color indicates, so a purple color indicates basically a purple color indicates a carbon dioxide level less than 0.5%. A beige color B, basically this B indicates a moderate level of 0.5 to 2%. This is the beige color. Okay, a yellow color C, which indicates a high level. So this yellow color C indicates a high level, more than 2%. Okay, so the minimum concentration of carbon dioxide required to produce a color range is from the color change, sorry, is from the range of 0.25 to 0.6%. So this is the concentration of carbon dioxide that is needed to produce a change in color from 0.25 to 0.6%. Generally at 0.54% change in color occurs. Okay. The hygroscopic carbon dioxide detector can last for a few minutes to several hours, but depending upon the humidity of the gas. However, reducing an HME filter, if an HME filter is used, it basically reduces the humidity of gases and can prolong the carbon dioxide, the measurement. So HME will increase the measurement time. So for few minutes to hours it can be used. It depends on the humidity. If humidity can be decreased. Now what are the advantages and disadvantages? So basically the advantages are the device is easy to use. It is not, the performance is not affected by nitrous oxide or any anesthetic gases. Small size, easy portability, no need of a power source. The cost is, it is cost effective. It can be used in diagnosis of esophageal intubation. So diagnosis of intubation, it can be used. It can be used for resuscitation. So carbon dioxide monitoring to know whether endotracheal tube placement is correct during resuscitation. This can be used instead. There is minimal resistance to flow. It does not increase dead space. So minimal resistance to flow. Then it is always ready to use. No calibration is required. And there is no interference with carbon monoxide. Now the disadvantages. So before a reading is got, several breaths need to be taken before a reading is got. False negative results may appear because it depends on the number of breaths that have to be taken. So during cardiopulmonary resuscitation, a positive test indicates that the tracheal tube is in the airway, but a negative test will require an alternate method of confirming. So just because this shows a negative test does not mean that it should be taken out, because first of all, the patient is not able to breathe. The respiratory rate will be low after resuscitation. So there are chances of false negative. So drugs that are introduced into the endotracheal tube can interfere with the reading. The false positive also can occur. Okay, so now if there are any acids in the stomach, if any acid ingestion or something, if the esophagus gets intubated, so that acid will give a false positive result. It can produce a false positive color because from the acids from the stomach. Then there can be some to differentiate the colors, there can be some problem. There are no alarms, right? There are no alarms, no carbon dioxide waveform to know if there is any change, if there is any bronchospasm etc occurring. You need a waveform to diagnose that. It uh, it may be cost effective for routine use, but it has smaller number of applications. It has to be changed continuously, so it is not that cost effective also. Then airflow obstruction may occur from a defective piece. And so basically it's mainly limited to tracheal tube placement detection, but it cannot be the only source of detecting tracheal tube placement. It has to be confirmed clinically too. Now the effect of atmospheric pressure, basically the EtCO2 partial atmospheric pressure, the partial atmospheric pressure into 100. So at atmospheric pressure of 760, the EtCO2 is 38, 760 minus 47 into 100, that is 5%. At atmospheric pressure of 500, it is 8%. So the EtCO2 changes with atmospheric pressure, and the manufacturer has to make adjustments. The manufacturer has to make adjustments to this, right? So he has to make the adjustments, and it has to be made known to the person. Then influence of water vapor. So effect of condensed water vapor. Water vapor may condense on the window. This we already discussed. May condense on the window of the sensor cell and absorb infrared light, thereby producing a false high carbon dioxide reading. So the temperature of the sampling gases may decrease during the passage from the patient to the unit, resulting in a decrease in partial pressure water vapor. This can cause an increase in carbon dioxide, right, by about 1.5 to 2%. So coming to, there are two types of capnographs, that is your volume and your time capnographs. So two types of capnographs. They are not, volume is not used so much, but there are two types that you will need to know: volume capnography and time capnography. So this is your normal volume capnography curve. Basically, your volume capnography is the shaded area between F and E. Okay, basically volume capnography represents a dead space. The area includes basically indicates the volume of carbon dioxide exhaled per breath. So in this black area, this is your volume of carbon dioxide that is exhaled per breath. So you just need to know that your volume capnography indicates the volume of carbon dioxide exhaled per breath. So the expired carbon dioxide waveform is plotted against expiratory flow rate, and allows calculation of total carbon dioxide reduction and respiratory dead space. It is not widely used. This is your time capnography. This is what we normally use. We shall be discussing these phases tomorrow in detail, this 1, 2, 3, 4. But this is what is in use, that we usually use, that is the carbon dioxide concentration against time. Okay, it is simple and convenient. Can monitor non-intubated patients. Dynamics of inspiration and respiration, expiration, both are involved in the graph. Both can be monitored, and it gives disadvantages. It gives a poor estimate of ventilation perfusion status of the lung and of physiological dead space. That is more seen with volume capnography. So that's it, guys, for today. Tomorrow we'll be dealing with the capnography part 2. We'll go through this again if time permits. It is a little, tomorrow we'll be dealing with graphs and the explanation of the graph. Today I just gave you the technological part of it. And do use my code SASHA and subscribe. Tomorrow we'll be having class at the same time at 7 p.m. It's a continuation of this, so do log on and use my code and subscribe, guys. Thank you. Have a good evening.